The talk which actually is relevant to specifically to the intensives because uh, we don't treat arrhythmias like cardiologists. So the thrust of the talk would be on treatment rather than on identification, because when we are treating or dealing with arrhythmias, it's an underlying scenario of a critically ill patient rather than a stable OPD patient who has actually come with some kind of a arrhythmia in the 12 lead ECG. So the reaction has to be prompt, the identification has to be early, and there are certain key messages which need to be taken care of when you are actually confused, which is a common scenario in this practice. So the agenda of today's talk would be to look at the incidences, what would be the causes underlying critical care patients, two type of arrhythmias we all know, tachy and brady, and there are certain key home messages which every intensivist must remind himself of when he is treating these patients. Uh, this was a study which was published in 2001, Intensive Care Medicine. They had 133 consecutive patients with arrhythmias. Uh, they actually, not 310 arrhythmia patients, there were 278 tachy and 32 brady. The crux of the study was that you have a patient with arrhythmias, it increases the length of stay, which is actually increased from 4 to 14 days, and there was also increased trends towards mortality. So it may not actually impact the mortality of the patient, but there is evidence to prove that it has a very good impact on the morbidity of the patients. And VT and VF are the most common arrhythmias, and AF are the most common arrhythmias. Incidence and prognosis of sustained arrhythmias in critically ill patients. A lot of causes have been issued as far as the causes. It can be a COPD, it can be ARDS, pulmonary embolism, heart diseases, particularly patients with mitral stenosis where you have a hugely dilated left atrium. It's a very common cause of atrial fibrillation. Those of who you are dealing with the post-cardiac surgery patients will find that excessive fluid resuscitation in the post-cardiac surgery patient also leads to left atrial dilatation and is a common cause of atrial fibrillation and a cause of morbidity. So there are certain other causes in the ICU like inotropes, vasopressors, acidosis, invasive procedures, mechanical ventilation, and underlying cardiac diseases which make these people prone for all kind of arrhythmias. Sepsis itself has been also now categorized as an indicator for actually causing atrial fibrillation in critically ill patients. We'll start with basically the ventricular arrhythmias and then we'll go on to the bradyarrhythmias. Basically, ventricular arrhythmias are divided into two, wide and narrow QRS complex. It decreases the cardiac output by 30%. These are all the kind of ventricular arrhythmias that you know of: VPCs, idioventricular ventricular tachycardia, torsades, VF, and asystole as the end product of when you are not able to treat. PVCs are basically ectopic beats which generate in the ventricles, and they can be of two types, unifocal or multifocal. Unifocal are basically from single area of the heart, and multifocal are actually coming from all kinds of ventricular areas. So the treatment of unifocal is obviously different from the multifocal. The multifocal have got a worse prognosis because there are all kind of chaotic activity going on in the ventricles. Causes, as I've already told, for VPCs in a ICU patient can be electrolyte imbalance, hyperkalemias, hypomagnesiemias, calcium, acidosis, drug intoxications like cocaine and tricyclic antidepressants, enlargement of the ventricular chamber because of, say, excessive fluid resuscitation. Patients who already have a dilated cardiomyopathy, they're always prone for these kind of patients. Increased sympathetic stimulation because of inotropes that we routinely use in the intensive care setting, myocarditis, caffeine and alcohol injections, and sometimes even pacemaker leads can cause these kind of VPCs, particularly when you are actually planning to go towards the apex of the RV, but you are actually touching the septum, and you can actually induce a VPC, and sympathomimetic drugs. So VPCs, we all know how to recognize. It's a basically broad QRS, more than 0.14 second duration, and an inverted T wave. So these are the two kind of VPCs that are seen in the ECG. One is a broad QRS with an inverted T wave. The QRS complex can actually go on the upstroke or it can also go on the downstroke. The rate would be a little bit on the higher side, not exactly like the VT, which is actually more than 140, but it would be somewhere between 100 to 140, but it's not that even in a slow rate you cannot have a VPC. QRS complex, we know it's enlarged and can go up to 0.28 seconds, so we can actually have a double QRS complex, and the treatment is no treatment to be done if the patient is hemodynamically stable. If there's a cause which you think is in the form of hypokalemia, hypomagnesemia, underlying acidosis, that needs to be treated. No IV antiarrhythmic to be intervened at this point of time till the patient is hemodynamically stable. Then obviously we know that VPCs can convert into a VT when they go through an R on T phenomena. Now what is R on T phenomena? Basically there's a natural beat coming, and before the T wave of the ECG stops, you have a premature beat on that. So which leads to a ventricular tachycardia. As you can see, before the end of the T wave here, there's a premature complex that has come and has induced a VT. So this is R on T phenomena, very commonly seen in the ICUs, needs to be treated the way you treat any ventricular tachycardia. We'll come to the details of that, but needs to be identified. Now this is a non-sustained ventricular tachycardia because it's kind of gone ahead and converted into a natural rhythm, so the cause needs to be taken care of. Then you can actually have a progression from VPC to a sustained ventricular tachycardia. The heart rate is high. You can have a slow ventricular tachycardia also under a patient of dilated cardiomyopathy, but most likely the heart rate would be high. You cannot identify on the PR interval. It's a broad QRS. You can identify monomorphic ventricular tachycardia. Treatment is basically depends on what is the hemodynamic stability of the patient. If this kind of a patient is hemodynamically stable, you would give antiarrhythmics in the form of amiodarone, or you can also give beta blockers. You can give calcium channel blockers also. If the patient is unstable, synchronized cardioversion is the way to go. Please remember, hemodynamic instability, there is no criteria of what should be the blood pressure. So if you have a blood pressure of 150 and with a VT it drops to 100, it's basically a unstable ventricular tachycardia. Although the systolic pressure is still more than 100, but look at the fall in the blood pressure, it's more than 20%. So if it's an unstable ventricular tachycardia, go ahead and cardiovert the patient. Practically, if you are confused whether you want to start antiarrhythmic or an electric charge, electricity is better than antiarrhythmics when you are in a scenario where you don't know what to do. So if you are confused what to do, synchronized cardioversion is the way forward, and then you can always decide how to move. So if you are confused, go ahead and cardiovert. Two kind of VT, monomorphic and polymorphic. Monomorphic is easily treatable. Polymorphic, as I told you, is coming out from various ventricular areas, so difficult to treat. The treatment remains the same, stable or an unstable tachycardia. Torsades de pointes. This is a very common arrhythmia and easy to recognize. It's basically occurring because of delayed ventricular repolarization, and there's a prolongation of the QT interval. So if you have a patient on amiodarone, or there are a lot of, you have to do a daily ECG and look at the QT interval in the ECG. If the ECG QT interval is actually going to prolong, the patient is actually getting prone for a torsades de pointes. So that is one thing you need to take care of. There are a lot of drugs that have been told to be causing torsades. Antiarrhythmics like disopyramide, procainamide, not available in India. Sotalol is not available, at least I am not aware of. Amiodarone we use very frequently. All kind of psychotropic agents like phenothiazine and TCS cause these, and more importantly in our settings, electrolyte imbalances. Hypokalemia, hypomagnesemia, hypocalcemia, they are all causes of torsade de pointes. It's easy to recognize arrhythmias. Look at this, how it presents. Basically, it's a spindle-shaped arrhythmia. You will see a spindle-like of waveform. It's a QRS pattern where one wave is going downside, the other wave is going upside. So this is a classical torsades de pointes. The QRS interval is prolonged, and there's no way you can identify the PR interval, no way you can identify the P wave. So it's not a classical VT. It needs to be differentiated from a VF. A VF has a sine wave pattern, means you will have a irregular kind of thing. This has a spindle shape pattern. It will move on like this. So that is how you recognize torsades. There are two kinds of torsade. This is the spindle-shaped torsade that I was talking about. It's a sustained torsade where you basically need to treat the cause. And the more common causes are electrolyte imbalance and antiarrhythmic drugs. This is how you differentiate VF. As I was telling you, the VF has a sine wave appearance and the torsade has a spindle-shaped appearance. The treatment is completely different. So it's very important that you recognize this redness. It's common in our kind of scenarios. So treatment is to remove the corrective, the causative factors. In an emergency settings, you can do a temporary pacemaker in order to maintain the cardiac output. Overdrive suppression of the arrhythmias can be done. Now this overdrive suppression, if you use a pacemaker, it has a last button on the end of the pacemaker which you can actually turn to a rate of 200 and above, and that is called as overdrive pacing. So you are basically taking over the normal activity of the ventricle, which is at a rate of 140. It is recommended for treatment of refractory atrial fibrillation. It is also recommended for treatment of torsades. But this is a last scenario where you have a refractory heart arrhythmias which not getting corrected with your standard medication. You can go for a overdrive pacing of 200 and above. Drug therapy, magnesium, as I told you, is the standard treatment because of the electrolyte imbalance. Drug therapy with isopropanol or beryllium has been used in selected cases. And if it's a sustained episode, you can also attempt a cardioversion. So these are the treatment strategies for torsades. VF, it's very easy to identify. I will not go into details because there are two kinds, fine of course VF, and we all know we have to follow the regular ACLS protocol for a shockable rhythm. Recognizing is quite easy. Causes, there can be huge lot of causes, but the most common cause is coronary artery disease. As has been told in the previous lectures, if you suspect a CAD as a cause and a patient has an ROSC, there is every likelihood he will go into VF again. Please go for an urgent PCI and a PTCA plus stenting of the culprit vessel, preferably within 6 to 12 hours. So most common cause is a CAD, ischemia, untreated VT. Dilated cardiomyopathy patients are very prone for ventricular tachycardias and ventricular fibrillation, but most of them have a implant in the form of a ICD or a combo device in there, which will actually keep on throwing the shocks when they have. These are all the causes which needs to be treated: electrolyte imbalance, hypothermia, drug toxicity, and acid-base disturbances. So this is a monogram from the ACLS, which actually shows that whenever you have a tachyarrhythmia with a unstable hemodynamics, go for a cardioversion. If it's a wide QRS more than 0.12 seconds, even if now it's a wide QRS, you can give adenosine now in a ventricular tachycardia where you don't know whether it's a VT or a SVT with aberrancy. Now, I have not deliberately included SVT aberrancy. Even it is very difficult to differentiate SVT with aberrancy and a VT. And the only way you differentiate is by giving a 6 milligram bolus of adenosine. So if you don't know how to identify SVT with aberrancy, treat it like a VT. Most common arrhythmias in ICU settings are ventricular tachycardia rather than with SVT with aberrancy. And the most common setting is CAD. So if you treat it like a VT, you have won the battle. So the thrust is on treatment rather than getting confused about what is the kind of rhythm. Idioventricular rhythm is the last thing that you see when you have gone through the whole thing and you have not been able to treat. We all know we need to follow the non-shockable pattern of the ACLS protocol. It's a bizarre QRS, low rate of which is basically ventricular, 30 to 40 beats. You can have idioventricular rhythm with a higher rate, which is about 70 to 80 per minute. QT interval is prolonged. P waves are directly opposite to the QRS complex. So as you can see, you can have accelerated idioventricular rhythm, as I was telling, where you have a higher rate, but it's not about the rate. It's actually about the cardiac output. So if you don't have a cardiac output, whether it's accelerated idioventricular or idioventricular, it is immaterial. Go ahead and treat it like a non-shockable phase of the ACLS protocol. Asystole, we all know that's the end of whatever you have done, and the causes are the same as they are for VF and VT, and the treatment is ACLS protocol. Now, how do you intervene in all these? You do oxygen therapy, CAB as I have been told. Please confirm that it's an asystole and vasopressin, epi, and obviously atropine has now gone out of this. Next, we come to the bradyarrhythmias. Basically, why is it occurring is because of decreased automaticity. There's less conduction of the
Dr.
atrial.
You have to summarize.
Uh, First degree AV block, we all know it's basically prolongation of the PR interval. Nothing needs to be done till the patient is hemodynamically stable, not even a TPI, not even a temporary cutaneous pacemaker. Type 2 is second degree is basically type 1 and type 2. From type 2 second degree, you need to start pacing your patients because these are the patients who can actually convert into third degree AV blocks. So type 2 second degree and third degree AV blocks need to have a temporary pacemaker in place. Obviously, needless to say, when they are hemodynamically stable, it's very difficult to have a patient who has a second degree type 2 or a third degree AV block and hemodynamically he is stable. So these patients will always be unstable. Go ahead, as an intensivist, everybody should now know how to put a transvenous pacemaker. Transcutaneous is obviously there in all the defibrillators. So, bradycardia arrhythmia algorithm is simple. If there's an instability, you go ahead and pace, wait till the effect. For that, in between you can give atropine, but the final treatment is a temporary pacemaker. So there are 5 general principles which I would say. Not all arrhythmics need to be treated. The cause needs to be treated. All arrhythmias don't need to be treated because all antiarrhythmics are pro-arrhythmogenic. Electricity is generally safer than drugs. So when you are confused, go ahead and do a synchronized cardioversion. Control all correctable factors which are in the form of electrolyte imbalances and acid-base disturbances. Treat the treatable ischemia. Till you are able to treat the ischemia, your rhythm disturbances will not get controlled. Consider your intravascular lines because that can also be a cause for your so-called ventricular VPCs and ventricular tachycardias. Consider always when you have a patient with arrhythmia, there could be a drug toxicity, particularly if you are working in a heart institute and patient is already on digoxin. So that's a very, very important cause of arrhythmias in underlying cardiac disease patients. Antiarrhythmics, you can give any antiarrhythmic. It's not important to remember the class. It's important to give it at the right point of time. Anti-tachycardia pacing, I have told overdrive pacing, you have to go to around 200 beats per minute and take over the complete control of the ventricle. Thanks a lot.